It's your girl Philosophia, um, and I am here to talk about joint pain, or rheumatology, and we're going to start off with joint pain because the fact of the matter is that with rheumatology, a lot of the conditions have some sort of arthralgia, some sort of pain in the joints, and it can either be acute or chronic. Okay, so let's start with the acute first, since that is a little bit shorter. So, acute, when it's coming in red hot, tender, swollen, a part of the diagnosis and also the treatment in some cases is anthrocentesis. So, you get a needle, stick it in the joint, take it out, you're decreasing some of that pressure, and at the same time, you can send it up to lab to see um, if it's has some sort of pathogen in it. And to be honest, you can make a pretty good guess just right there during the anthrocentesis, because depending on what the kind of color opacity of the um, liquid might be can help direct your diagnosis. But, anyways, back to acute joint pain. A lot of times these are going to be like monoarticular, so only affecting one joint. And if it's a trauma, then you just want to look for whether there's a fracture somewhere. And so, in that case, you would definitely want to get a CT. And then, if you get it back, the anthrocentesis, something you would want to check is if it is a crystal or if it's an infection. Let's go down the crystal. So it can be negative or positively birefringent. Um, if it's if it's positive, then you're looking at pseudo gout, and pseudo gout is basically a lot of deposition of calcium pyrophosphate, and you would see these rhomboid shaped cells. You want to treat that with colchicine. NSAIDs are really for symptomatic treatment, but nonetheless, it is still indicated. Next, gout. Gout is a really important diagnosis. Typically, you'll have maybe this like um, obese patient who was out with some friends, drinking and, drinking a beer, eating some steak, and all of a sudden they get this like acute pain in their toe, their big toe, and they have a past medical history of kidney disease. Okay, right there, you are definitely going to be start thinking about gout, and the gout is basically the buildup of uric acid. That acute toe pain is called podagra, and you'll basically, if you were to biopsy that, you'll see basically a buildup of cholesterol. Um, the ways you treat this is by using colchicine, NSAIDs for symptomatic, um, steroids, and lifestyle changes. Your goal is to get it under uric acid under 6. Um, Sometimes patients may not be the drinking a lot of alcohol or eating a lot of red meat. It might be that they have leukemia or lymphoma. And these cancers tend to have a very high cellular count. And so when you are treating patients for these cancer, you want to be mindful that this might precipitate hyperuricemia. And so just be mindful of that. If the case, prophylaxis would be giving them IV fluids, allopurinol, which is an xanthase oxidase inhibitor. Xanthine oxidase is important in the production of uric acid. Um, And then also there is riburicase, which is a uricase analog enzyme. You might have seen like in Sketchy the pulgadicase, that vine in the back of the church. If you remember that, or if I'm explaining that right. Anyways, so that is it when you see crystals. You're not really going to have high cellular count. It's definitely going to be underneath 50,000. Septic, you're really thinking gonorrhea or non-gonorrhea. And in gonorrhea, you just want to basically treat it like an STD. So this is going to be diagnosed via a nucleotide amplification test. Um, gram, gram stains don't really work for gonorrhea because Neisseria is an intracellular pathogen, so you can't really stain something that's already inside an cell, so that won't work. But you do want to treat with ceftriaxone. And then whenever somebody comes in with gonorrhea, they are likely to have chlamydia. So you want to treat with doxycycline or azithromycin, period. Always do that together. All right. And next we have staph, usually like Staph aureus. And so this can be a direct inoculation, like from trauma or something, or it can be homogenous, for example, from IV drug users who may not be using clean needles, or from people who have to get who have to get repeated blood transfusions as well. These would be gram stain positive. So you'll see these purple clusters. Remember the grapes from Sketchy. Um, Treatment, if it is methylene sensitive, then use nafcillin. And if it's methylene resistant, then use vancomycin or linezolid. But I just remember vanco. All right. Next, we're going to go to a more chronic form. And we have, in my mind, I separate them as if it's inflammatory, non inflammatory, or degenerative. So if it's degenerative, then that's osteoarthritis. And for osteoarthritis, um, you are typically looking at this obese patient who's maybe had a prior injury to their knee or something and it keeps bothering them. And so this is basically kind of your clue that this is osteoarthritis. All right. One of the things with osteoarthritis is that it's a wear and tear. So that means the more you use it, the worse it's going to feel for these patients. You want to understand that on when you're trying to diagnose this, it's it's likely that you're going to get most of what you need from the clinical history, from history taken. You maybe on physical exam may see a bony enlargement, maybe a little red and tender in that area. It's usually on weight bearing joints. Maybe when you're moving it, you might like feel or hear some popping noises, and that's crepitus. Um, and so, yeah. But if you must continue on with your diagnosis, an x ray will be helpful. You'll definitely see narrow joint spaces, osteophytes, and just subchondral sclerosis from the constant rubbing. Key with this is on amphiocentesis, you're going to have a serous. That means you will be able to see right through it, okay? Because this is not an inflammatory disease. Now, if it is an inflammatory disease, then it's going to be cloudy, okay? Septic is straight up opaque, but inflammatory, it's not necessarily above 50K, so but it's not lower than 2K, So like maybe serous or something, a serous. So inflammatory will be cloudy. And I Now, if it's cloudy and it's only one joint, then I would kind of maybe cloudy to opaque, I would kind of move towards my septic. But I typically like to just say, okay, down my list, the patient complains about chronic pain. Is it inflammatory or is it degenerative? If it's inflammatory, is it injuring? Is it affecting multiple joints? If it's affecting multiple joints, is this something that could be seropositive? Are there some serology tests I need to order? Or is this something that looks seronegative? Okay. So let's start off with seropositive because that's really the bulk of like what you would be seeing. And I'll begin, since we just did osteoarthritis, I'll begin talking about rheumatoid arthritis. And with rheumatoid arthritis, this is going to be on symmetrically distributed small joints, and usually greater than 3. The key thing with this is like especially when it comes to the hands, it's going to be sparing the DIP, so the very last joint in your finger, at the tip of your finger. You won't have problems there. You may see some ulnar deviation because of the way this disease kind of just eats at the joints, but you will not have DIP problem. And a lot of things with these inflammatory joint diseases is that you will have a better response after exercising. So when you get those joints moving, you give the inflammation less time to occur. Right? And so you definitely want to just, have that in your mind when listening to the history. So the patient may wake up with morning stiffness, but by the end of the day, they'll be fine. The another aspect of their stiffness that just can be important when it comes to treating, or it could be like a minor test question, is that you have to be careful when you want to intubate these patients, especially if they did say that their neck has been stiff, because they could be prone to subluxation in the C1, C2 area. Like, for example, again, if you want to intubate them. So an x-ray may be indicated. You will see nodules on the fingers of these patients, and something else that like a subclass of rheum is called Felty syndrome, and so that has RA, neutropenia, and splenomegaly. So that's an important thing. Another like more specific, so rheumatoid factor is not really that specific. It is sensitive, so it's going to be positive, but you'll see that in like other diseases. The key thing here is the CCP, because there are certain amino acids that just get metabolized differently, and especially in states or in rheumatoid arthritis. On X-ray, you will see pannus formation, so that's basically just a glob of immune leukocytes and destroyed tissue and stuff like that. So you'll see periarticular osteopenia, and those are like buzzwords. That's the goal of this whole thing, is for you to just know the buzzwords, so that it can help you truly understand the disease. All right. Treatments. It's going to sound like a broken record by the time I'm done with this video, but you want to use NSAIDs. DMARDs, but don't use DMARDs if the patient is having problems with their axial skeleton, so their back, maybe a little bit of their hips. So you kind of want to be wary there. But nonetheless, DMARDs are good. Biologics like TNF alpha inhibitor. Just remember, like I said, that TB can be an issue there. And then steroids, but you only want to use steroids if there's a flare up. All right. moving on to lupus. Lupus is something that is very much so um, a lot of problems kind of everywhere. Um, when you get the clinical picture of it, you kind of have this, you know, picture where there may be a malar, a butterfly shaped rash on the face. They may have had some ulcers in their mouth. Of course, again, they were complaining of joint pain. The rash might get worse whenever they go outside. They look like they're anemic. Um, they will die from renal failure or neuro problems. Okay, so you might alter mental status. That's a really bad prognosis. Now, one of the key things with, and you can see I use this mnemonic MD Soap Brain. I've seen in first aid like other different mnemonics. So I mean, pick whatever you want. Just make sure you're like you can be able to remember enough to make this, because I think a clinical diagnosis takes at least 4 symptoms if I'm not mistaken. But anyways, the with lupus, the serology is kind of important. So you want to make sure it's NA positive. Now this is not the end all be all when it comes to lupus, because you can definitely have ANA in other organs, other diseases, but with lupus, why this becomes significant is if this is negative, then you can pretty much, rule out lupus. But other serology tests you may want to run are the double-stranded DNA, and that's especially like if you suspect there's a renal issue. And then I also want to point out about the antihistone, because that can be drug induced. So you might think of, let's see, the class 1A antiarrhythmic, procainamide, that can cause lupus. A TB drug like, oh, I am blanking on the name, but I know you can probably recall it, like in Sketchy, the the wolf that is there at the wall. But anyways, that, and there are other ones as well, like for hyper drugs that cause that help with hypertension, especially gestational hypertension. That might be something also to remember as well. Um, Going ahead to your anti or some other things is that sometimes with lupus, the patient may be or a lot of times with lupus, the patient may be in a hypercoagulable state. And this is due to the fact that they have this anticoagulant. And so, even though it's an anticoagulant, you're going to have a falsely elevated PTT because, again, hypercoagulable. So they may be prone to miscarriages. Another thing is they may look like they have syphilis because of this antiphospholipid. So that's just another thing to just be aware of as well. Treatment, hydroxychloroquine is mainstay, and then steroids if there's a flare, and then cyclophosphamide, IV, and then by mouth mosfatil, especially and that's really like in the case of nephritis. So you want to definitely make sure you have a UNA before you start administering. Okay. And next we have sclerodoma, and with sclerodoma, um, derma, you have atrophy of adipose tissue, activation of fibroblasts, causing a lot of collagen deposition. Maybe you can tell me, but what type of collagen is deposited? I remember having a test question about that. So y'all let me know. But anyways, there can be a diffuse or limited. For limited, I'm pretty sure everyone kind of knows this mnemonic about the crest. So using that, you can pretty much be able to tell that you're dealing with limited cutaneous. I just want you to remember that C can stand for calcinosis, also for anti-centromere. You also have the diffuse cutaneous, and so you have these cutaneous symptoms, but then you also have visceral involvement. So that may be the lungs, that may be the heart, that may be the kidney, etc. And in this case, you're going to have damage to those organs. So even though in limited cutaneous, for example, you have pulmonary hypertension, the lungs there are still fine. But in diffuse, lungs are going to be jacked up because of this interstitial lung disease. You may have constricted pericarditis, again, renal crisis. And at that point, you really are just trying to manage symptoms. You can't really treat scleroderma. But with scleroderma, I remember actually the very first patient that I saw with scleroderma, and it was pretty cool the way she had handled everything, because she used, instead of, feeling that, this disease has conquered me and this disease runs my life, she spun it around and she actually goes to other medical schools and shares her story and shares, aspects of these diseases. And she had like textbook scleroderma, the diffuse kind, because she was hospitalized because of her lungs messing up. But she had the shiny skin. She had like little white, patches on her skin. I'm pretty sure if it was colder, her fingers probably would have turned different colors. She definitely said that she has digestion issues or like reflux. And so that is definitely a thing. Um, and when I was examining her, I did not see the telangiectasis. Sorry, I'm saying that word wrong, but I did not see that. However, I'm pretty sure maybe if I went back again, I probably could find it now that I know what that looks like. So just wanted to, let you know, like, I think whenever you see a patient having a disease you study, it's really important to listen to their story. One, because they have a lot of insight into the disease, and two, because it's going to help you remember it forever. Like, I won't forget, the symptoms of scleroderma because of her. All right. Anyways, moving on. We have Sjogren's disease, and I like to think of Sjogren as in the name, the little mouth and eyes, because you're going to have dry eyes and dry mouth. The bilateral parotid swelling, because parotid is one of the main producers of saliva, and you're not making that saliva, so they're going to complain about like a dry mouth. They actually have a higher risk for non-Hodgkin's cancer, so you want to be aware about that. Serology, anti-Ro, anti-La, and yeah, so treatment is basically just giving them tears and saliva. It's an annoying disease, but it's not really going to kill somebody. All right. So myotitis is basically what is remaining in the seropositive diseases. Here, the patient is going to complain of muscle weakness. Right. Remember, I just said this: muscle weakness, not pain. they'll say like, oh, it's just so hard to get up from my seat or go downstairs or comb my hair. So proximal muscle weakness, it's painless. They do have a risk of occult cancer, so maybe ovarian cancer or GI. So maybe you want to look for CEA or CA125, that kind of thing. There are really two types, and I'm gonna just draw it out right now. So there is dermatomyositis, myotitis, and then there is polymyositis. All right. The things that you have to know for this is, for the first one is you're gonna have what I've put stars by, heliotrope rash, so they'll look like a raccoon. The Gratton's papules or red bumps on their fingers, maybe, and shawl sign, like as if they're wearing a shawl. This is a CD4 disease, CD4 positive. So, a way that I've seen this written out, actually, which helps me remember, is that the A is made like a 4, and then you have your positive sign here. Okay, that just, I don't know, that helps me. And this is CD8 positive. Okay, so the dermatomyositis is basically going to not only affect the muscles but also the skin, so that's why you get those signs. But polymyositis stays within the fascicle, so it only really affects the muscles. If there's a muscle problem, you're going to get an EMG. That's like super important, all right? And if you do see muscle damage, a way to confirm is looking at the CK or during a biopsy to see maybe the lymphocytes, and then looking for your serology, looking at anti-me and anti-Joe. So I don't know, I look like a Auntie Mimi and Auntie Joe. So because I think it's 2 right here as well. So, all right. So that is basically all the serology positive. Just to recap the serology that you do want to know. Test for rheum CCP, for lupus ANA, anti-DNA, double-stranded DNA, antihistones. For scleroderma, if it's limited, then it's anti-centromere. If it's diffuse, then it's the topoisomerase or SCL70. Myotitis is going to be anti-Mimi and anti-Joel. And then Strogen is going to be anti-Ro and anti-La. Serology is important, I think, for conceptual purposes, but really these diseases you can get to them via clinical diagnosis. Okay, maybe you use serology to like confirm. All right, going to my seronegative, we have this mnemonic I'm sure everyone knows about. It's called PAIR. So it's for psoriasis, ankylosing spondylitis, IBD related, and then reactive arthritis. All right. So first for psoriasis, you're going to see these silver plaques, scaly, and you're going to see nail pitting or just some sort of nail weakness. You want to treat with a vitamin D analog because the skin cells seem to respond well to that. And yeah, so that's pretty much it. Um, for IBD related, you want to treat the IBD and you'll end up treating the arthritis. Ankylosing spondylitis is a big one to know, I think, out of all of these. And that is basically, you'll have this man that has Back pain, it improves with the activity, but he might come in like with breathing problems too, and not really understanding what's going on. So in your mind, you're like, okay, well, a young male is coming with back pain. That's gonna make me think of and when I tap his sacroiliac joint, it elicits pain. So that's gonna make me think of ankylosing spondylitis. With ankylosing spondylitis, you're gonna have impaired spine mobility, and that can restrict the lungs. So even though the lung compliance is okay, you're gonna have this picture of a restrictive lung disease. So low FVC, low or normal FEV1. They're gonna be again shortness of breath. Residual volume is not really going to change because it's not an issue of the lung itself. It's an issue of the rib cage, really. Um, this is associated with uveitis and pain in the heels. The Achilles tendon gets inflamed as well, the point of attachment. You'll see syndophytes, desnophytes, and that's basically going to help you see like or make it's fused bone together. Because what happens with ankylosing spondylitis is that the bone degenerates and then repairs. It generates repairs, but it repairs faultily to the point where the bones end up becoming fused together, forming this like bamboo spine. I'm sure if you've heard of such. And we're going to have reactive arthritis lastly. Reactive arthritis, you just want to know the three, okay? Urethritis, arthritis, and conjunctivitis. Can't pee, can't see, can't climb a tree. We all know that mnemonic, right? So that is something that's really important to know. You want to treat it um, like usually it's a post-infectious disease, so it might be post-GI or post maybe STD. So if it's in, like chlamydia, then like again doxy, azithro. You might want to treat gonorrhea as well. Just throw in ceftriaxone in there because those two go like a pair. Right, so that is pretty much when it comes to joints. But rheumatology is, I know rheumatology does really affect, is all about autoimmune essentially. So your body ends up attacking your own cells. We talked a lot about joints, but also it can happen in vasculature as well. And so I just want to briefly go over these. These aren't really that high yield, but for completeness sake, I want to talk about it. Starting with large size vessels, you'll see here for giant cell arthritis, this older woman comes with some like muscle pain, some maybe, and you're thinking, okay, this seems like maybe post myalgia rheumatica. Okay, you want to act fast if they say that they are having vision problems, because if that is the case, then they are highly likely to get blindness if they don't get a high dose of steroids. So this disease ends up affecting the external carotid, the ophthalmic artery, temporal artery. So they'll get pain when they're maybe claudication, like when they're chewing a lot, vision problems, headaches, but you really want to act fast if it's on that headache. If it's on a vision problem. All right, if you see a young woman and there's a discrepancy in pulse, um, that might clue you in for Takayasu, and that is because the aorta is mainly affected, and so just want to get an angiogram and then give steroids. Um, all right, next for medium size, we have Kawasaki and then PAN. Kawasaki is really in kids. You'll see these aneurysms basically. Both of them have deal with aneurysms, and you'll see in coronary arteries. So if a kid, and like this Asian kid, comes to you with desquamative rash on their hands and soles of their feet, they might come with conjunctivitis. They might also have they might have rash, desquamation in their mouth. Um, they will definitely have a fever, um, and they have a heart attack. Then you definitely want to consider this disease and treat with IVIG and aspirin, okay? I've seen the mnemonic crash and then burn, so that might be something to help you. All right, and then for PAN, especially if the person has Hep B, then this is like very much so the disease. You'll be looking for uh, a rosary look on the angiogram that ends up having that's a key word, transmural inflammation. Okay, and that is going to cause like stomach issues, kidney problems, purpura, even peripheral nerve damage. All right, last group is the onco related, and you can have Wegener's. You can also have MPO or MPA, yikes, and then EPA. I think it's MPA. All right. So with this, you have with Wegener's, you have C-ANCA, So with these, you have hemoptysis and hematuria. But with Wegener's specifically, you're going to have upper respiratory airway involvement, so maybe something in the nasal cavity or something like that. It would be good to do a lung biopsy so you can see the granulomas. That's what you're going to see. And you want to treat with steroids and cyclophosphamide. P-ANCA would make you think either EPA or MPA, and the thing about EPAs is basically the same thing as GPA or Wegener's, but it has eosinophilic, doesn't involve the nose, and no granulomas. And then MPA is also a P-ANCA disease. Next we have this cryoglobulinemia, and if the patient has Hep C, then you're likely to see palpable purpura, low complement, high IgG, IgM, and that is that. And then HSP, you're going to see palpable purpura as well, but this is going to have GI problems. The kidney form of this is Berger's disease. So it'll be the IgA nephropathy. That's important. And then you want to look for this leukocytic vasculitis and see a lot of IgA when you do a biopsy. And you treat with steroids. So, all right. That is the high yield, my high yield version of what you need to know for rheumatology. Hopefully this helps. Remember, we lift as we climb. All right, and I will catch y'all later. Bye.